Hello, friends and colleagues. Today, we are going to be talking about a particularly vexing problem in healthcare, and it affects us all. It's funny how much technology has taught us to change our expectations of the world. And I'm old enough to remember the days when every single piece of health information was on a piece of paper. In the military health system where I kind of grew up as a physician, that paper record had to follow patients around from clinic to clinic. And sometimes we pulled the records ahead of appointments, and it was someone's job to deliver them to wherever the patient had their next appointment. But more often, it was the patient's responsibility to come to the records department, check out their medical record, and hand carry it to their appointment, which might be in a different building altogether. Very often, records got lost. We had these little plastic sleeves where we would tuck in a single handwritten visit note waiting to be married with its chart someday. And we never knew when we looked at a chart whether it was complete or not. If retirees were seen at the VA couldn't see their military records. And when they came back to the military hospital, we couldn't see their VA records. If patients were lucky, some portion of their record might be faxed to the next provider in line. We wanted a complete picture of our patients, but we had no expectation that that would be possible. Now that the entire world, including nearly all of healthcare, has been digitized, we have a new paradigm. Those teeny tiny electrons fly all around us. They allow me to video chat with my daughter in Australia from San Antonio, Texas. And as a PCP responsible for the care of the whole patient, I feel like I ought to be able to have all the digital information that exists about my patient if I need it and my patient gives consent. That should be pretty easy, right? Wrong. It feels like there must be 1,000 EHR companies in the United States, and I know that a single payer system is a controversial long shot, but I would honestly settle for a single EHR. These systems do a very poor job of talking to each other, whether it's lack of standards, privacy concerns, proprietary blocking, technical complexities. We hardly do better than the days when we had paper charts. How is this possible? Recently, I was talking to a PCP in independent practice whose interoperability with the hospital system wasn't working. He contacted his EHR company and everything checked out on his side of the transaction. So he, the PCP, was instructed to call the IT department at a hospital, which used Epic, by the way, where he doesn't even work, to get them to investigate and solve the problem. And I have to be honest, as a PCP, I felt some rage about this. The PCP is just trying to take care of his patients and has enough to worry about and deal with. Why should he have to get in the middle of solving a technology problem between two technology entities? There has to be a better solution. And today, we're going to try to get some answers. Hello, and welcome to The Pulse, the Elation Health on-demand interview mini-series discussing hot topics across primary care, health tech, and the healthcare landscape. I am your host, Dr. Sarah Pasteur, family physician and Senior Director of Primary Care Advancement at Elation Health. The topic of today's interview is Breaking Down the Walls, Tackling Interoperability Challenges in Healthcare. Today's guest is my colleague and friend, Andrew Talbot. Andrew is a principal on the Research and Insights team at Elation Health. With over 6 years of experience at Elation, some of his greatest hits include working on building out our developer platform, interoperability, something called CERT, and building out sales and solutions engineering teams. Elation is Andrew's first job in healthcare, but he brings a wealth of experience having previously built family-oriented products with major mobile carriers such as Sprint and Verizon. Outside of work, Andrew lives in the Bay Area and is a devoted father of 2 children. In his free time, he enjoys reading and getting involved in local government initiatives. Welcome, friend.
Glad to be here and talking with Dr. Pastor. These are conversations that we have in private a lot. So I'm glad to be able to have this out in the public and talk about interop and all the great joys that go along with it.
Wonderful. Let's dig in here. So tell me about your role at Elation and how that intersects with our topic of interoperability today.
Yeah, so as a principal on the Research and Insights team, what we're trying to do is really understand how providers and groups and folks across our ecosystem as Elation customers are using Elation to be able to effectively deliver care. And one of the things that we've been looking at a lot lately is trying to understand how people are actually using some of these interop tools to be able to try and do that, to try and get a complete and total picture of their patient, what before they see them and when they see them, and hopefully after as well. And so we're trying to really dig in and see what some of the tools people are using, what's working well, what's not working well. We can find some of those kind of diamonds out there that we can kind of talk through and see how we can spread the information to everybody and to really be able to inform ourselves on what we need to build next to support this.
Cool. So for those of us who are not very technical, but without getting too technical, what exactly is interoperability and how does it happen?
That's a great question, Dr. Pastor. And, like yourself, I've been around for a while as well. And one thing I remember is that we had a world before cell phones. And at that time, you would call folks on the phone. But as cell phones started coming around, there's this thing called texting that people started to do. And think about trying to text between Verizon and AT&T, different carriers, even maybe across countries. How does that all happen, right? At this point in our lives, it's kind of all magical. It just sort of works. But there was a huge amount of work that those carriers, those groups did to make that happen. So it's interoperable across those systems. And so when you text someone, there's a spec that says what that's supposed to look like, how that's supposed to work. There's a spec that says, here's the errors, here's the issues that you might hit, and there's different conformance requirements that people have. So if they're not following those, that there's different bodies that can kind of sanction them. There's places where people can go theoretically to try and solve that. But anyone who's kind of lived through that could see that there is times when you texted someone and maybe text them an image, you had no idea if that picture was going to show up. And so it's a similar sort of thing to that, is that there are a standard that people are supposed to follow, that your EHR is supposed to follow, that some other system is supposed to follow, that hopefully you can send information from one system to another, but everyone has to follow that standard. Everyone has to agree on the words they're going to use, on the structure they're going to use for the data, and that doesn't always work.
But say more about that. Like, why doesn't it always work? Why is this so hard? The fact that we haven't made more progress here, because, I love the texting analogy. We've made a lot of progress there. Why haven't we made more progress in healthcare?
So the amazing thing is texting is actually a lot simpler, and there's fewer groups. So if you think about it, think about that game that you play at camp, telephone, right? So you start, someone whispers into someone's ear and says a phrase, and then everyone goes around the room and they whisper back. And when it gets back to that last person, usually it's, it starts out, hey, how's it going? And it ends up purple monkey dishwasher. If you have 10 people, it's going to get worse. There's going to be more errors, more problems. If you have 4 people, though, it might be a little bit easier. Maybe you can all sit down and agree and say, here's how we're going to do these things. So there's fewer errors. So when you have fewer carriers, bigger groups, it's easier. So for better or worse, American healthcare, we have a lot. We have a lot of everything. We have a lot of different EHRs, a lot of different tech companies out there doing different things. And so when you have a lot of people are going to implement things in different ways. And even more than that, texting is simple. It's just text, it shows up. We're talking about health data. And so people's interpretation of what health data looks like, how that works, that's a whole nother spec and whole nother issue that people need to deal with. And so you have a more complex set of data, more information, more interesting information, and you have more people trying to communicate. You're going to end up with more errors, more just kind of mutual incomprehension.
Um, Sticking with that texting theme, I have noticed from time to time, even like iPhone to iPhone sending iMessages, sometimes messages don't go through, and I just didn't know it, and they didn't
Right.
know. Who the sender and receiver both just didn't know that that didn't happen. And so if I'm sending health information about my patient to a subspecialist or they're sending information to me, how do we know that it got over the fence and was arrived complete where it was supposed to go?
Yeah, and in that situation, right, you text someone, you don't know if the text went through, and maybe you're in a bad, area with bad signal or something like that. What do you do? Well, you maybe you call them. Maybe you maybe you're going to see them later, so you ask them. It's useful to have different channels. So that's what we see a lot in healthcare is that people will try whatever channel they can to make it happen. So they'll text, if they'll use direct message, for example, which is kind of like email with a secure sort of connection and set up around certification. Um, Maybe that didn't work. Maybe it did work and the person didn't respond. So then they'll go and they'll call, or maybe they'll fax. Maybe they'll send someone down to the hospital and try and see if they can flag that person down. So it's similar in that it's useful to have those different kind of bands of way to communicate. And sometimes maybe one will work better than the other. And so that's often what people try and figure out. It's like, all right, this group, if I fax them, will this work? If I direct message them, will this work? This kind of passive care quality Commonwealth situations, will that work effectively? And people kind of experiment and see what works and what doesn't work. But it's hard to know if something's working or not.
I mean, I'll be honest, I don't love that. I want it to be smoother. And I thought that CERT was supposed to make sure that certified EHRs ensure smooth data exchange between healthcare providers. So, what is CERT and why isn't it making things work better?
Yeah, CERT itself is a huge topic and exciting to talk about and always fun. But it really comes out of if you think about what you could do. Let's come back to that analogy with that kind of game where you're at camp and you're kind of going around the ring. If there is someone standing there and saying, you need to make sure you use words that are easily understandable. You need to only, you only use the and when you're doing connection or something like that. It's going to simplify things. People are going to be able to agree, work together. And so what we've seen is the government and then working through CMS, Center for Medicaid Services, putting out kind of requirements that say, if you are a certified health technology, you have to implement some of these things to be able to interop together. So for example, being able to support CCDA effectively, which is really just a way of structuring health data so that machines can read it easily. Being able to use what's called direct messaging, which, like I said, is kind of it's like email. So it's like making sure you can email back and forth, but also has some extra security features so that I, as a healthcare organization, know that I'm not sending, you to some random place out in Siberia. Um, and what that cert requirement does is it forces you to go through conformance testing. You can test and say, hey, we implemented this correctly to the spec that the conformance tester says. Now, unfortunately, and this is something that CMS is, I think, doing a good job of trying to address and think about, is conformance testing means that in a lab, I sent this direct message and the tester said this worked well. I sent that CCDA along with it, and this tester said this data was in it. But in the real world, people make different decisions. And those may still follow the conformance properly, but there's kind of still that mutual incomprehension. And maybe the decision that looked like it didn't matter during testing actually mattered in real life, and just things aren't working. People can't see what the patient information is. People can't see, so they can't know which patient to route this to. People can't see who the sender was, or either who they're sending to. That won't work. So, um, the difference between what works in the lab and works during testing and what works in real life can often be kind of that huge gulf that makes it really difficult for people to actually use this stuff.
So this was actually kind of an aha moment for me listening to you talk about that because um, I had been thinking of CERT in terms of certified EHRs that then allow for MIPS reporting and things like that, which, not all PCPs would need. So, and I think a lot of PCPs don't even know that some EHRs are certified and some are not, and why that's even important. And what I hear you saying, I think, is that CERT is intended to standardize not only the format of the data, but also how we transmit it so that we're all on the same page so that we can make this exchange smoother. And any PCP working in any environment is going to want a certified EHR that conforms to those standards so that they have a better chance of interoperability. Yes?
Absolutely. One of the things, the way I think about it is it provides that kind of least common denominator. If you think about it from the government's perspective, how can we make it so that, I as a patient have an experience that is somewhat consistent? If I end up in my PCP's office, I end up in a big hospital system. If I end up some other random place, maybe on vacation. And so that consistency is, part of that is so that we can report and say, hey, this technology is valuable. But part of that is just so we can say, hey, like this thing's going to work well wherever you are as a patient. Um, and part of that is making sure that, the data transfers.
Yeah. Yeah. So I mentioned in the opening, I talked about a PCP who got stuck in the middle when interoperability failed. So whose job is it to debug this when it doesn't work?
So this is the problem where this is why they hit this issue, right? It's no one's job. There's no one who's directly responsible because you have one side that says, hey, we met the spec. This other side says, hey, we met the spec. And together they're disconnected. They didn't hit each other. They're not testing against each other. They're not hitting the spec. So some groups to get around this, you see this historically before CERT and before other stuff, they would build their own integrations. It's expensive, it's difficult, but you kind of hire someone or you do it yourself and you say, we're gonna figure out some data stream that works just with that hospital system, just with that PCP's office. So that's like one solution. So then there's someone responsible. We paid this person. Let's go to them and make sure that they're going to resolve it. For this other provider who I give my heart out to, like they're in a bad situation, they'll talk with whoever sold them their software. Maybe that'll help them. Hopefully that team reaches out. But I've had discussions where we've done exactly this. We've gone through and debugged something and looked at it, and the person on the other side that says, "Well, they're not my customer. They're not paying me. I can only spend 20 minutes with you just because I'm trying to be nice. But ultimately, I'm not getting paid for this." And so that's the problem, is that no one's actually responsible. And that means that there's no real accountability to be able to solve this.
That's so unfortunate, because it's not only putting the PCP in the middle, but it's putting the patient in the middle and putting patients at risk. From an industry standpoint, we really need to do a better job of this and like all work together. So, I mean, what needs to happen for interoperability to better support doctors and their patients and getting that complete picture so that we can start having more affordable, high quality care?
I think there's a couple things. One is that this conformance testing that people do. I think there's a few ways we could make it more real life. One is that we could kind of find different ways to peer and pair together in testing, so we can actually see it working effectively across um, different pieces of software. The second is that that we can make those testing kind of performance testing like something that's a lot more automated, something that happens consistently, and maybe we can make it something that happens in real life, so that like we were testing in our production system consistently, like on a weekly basis, on a daily basis even, so that we can see, oh, this is working effectively. This is what they said, this is what it looks like, and have that kind of be more public and available. That's definitely one thing. And then, you think about kind of governmental solutions. There's definitely ways that, we probably could establish programs where people can report, hey, this interop thing isn't working, and have some sort of remediation process where people have to work together. Because ultimately, if no one can take responsibility, we end up saying oftentimes the government has to. And so that probably won't work amazingly well, but it's something that we could do.
Yeah, actually, I love the idea of public accountability, of making that reportable to the public so the public knows like which vendors and which institutions are doing a good job of making sure that this is working for them. Well, Andrew, thank you so much. It was truly a pleasure to learn from you, and I hope you'll be back sometime. We'll talk about something else.
Thank you. This is a lot of fun, and I'd be glad to.
Great. So if you have questions or feedback about this content or have ideas for a future episode, don't hesitate to contact us at marketing@elationhealth.com. And thank you to all of you who tuned in to our discussion today. We're glad you're here. And to learn more about Elation Health, please visit elationhealth.com to access our webinars and a full library of our Pulse episodes. Visit elationhealth.com/resources/webinars. All other inquiries go to marketing@elationhealth.com. Thank you.